Hello, my name is Justin Moody. I'm a P3 pharmacy student from Philadelphia, and today we're going to be talking about oxycodone. Oxycodone is an opioid C2 medication that is a common drug that is abused and is very prevalent in the opioid abuse epidemic that we're experiencing today. Oxycodone is one of the semi-synthetic derivatives of morphine. It is 1.5 times stronger than its derivative. Like other opioid derivatives, it originated from the poppy plant. The poppy plant was discovered to have pain-relieving effects as well as euphoric effects. This is why it's been utilized. It binds to nerve receptors in the brain, blocking the body's natural pain receptors, limiting the physical feeling of pain throughout the body. Its mechanism of action is that it has strong agonist affinity for mu receptors in the body. So when it binds to these receptors, it's going to increase the blocking of the feeling of pain throughout the body, as mentioned before. Mu receptors are one of the body's natural receptors that combat pain. They're located in the brain and throughout the rest of the body. This binding is going to cause the hyperpolarization and is going to reduce the excitability of the neurons in the central nervous system, so you're not going to have action potential. Its metabolism is that it's metabolized by CYP3A4 and 2D6. The metabolites produced are going to be neuroxycodone and oxymorphone. These two metabolites are what are going to be released by the kidneys, or cleared in our case, when metabolism fully takes place. Just as a note, oxycodone is going to be metabolized into these two metabolites. So you can take the tablet, you're going to take the tablet by mouth, but when it's cleared, it's not going to be cleared as oxycodone. It's going to be broken down to these two metabolites. An important thing that you need to monitor is if this drug is taking any CYP inducers or inhibitors, such as HIV medications, or drugs like statins that are heavily involved in the CYP system. You don't want this drug to interact with any of these medications and not work as effectively as they're supposed to, or vice versa, where those drugs prevent the oxycodone from working as effectively as it is supposed to. Also, if you have interactions that may prevent the drug from being cleared, it's going to be sitting in the system, and that is going to raise the risk for side effects that are going to be mentioned later. Short-term side effects of this drug include stomach pain, dry mouth, increased drowsiness, headache, and changes in mood. Long-term effects are going to include breathing troubles, extreme drowsiness, muscle weakness, cold skin, losing consciousness, and constipation. Constipation is going to be the number one long-term side effect of this drug, and it's something that is not going to go away as your body gets used to it. It's imperative that doctors also prescribe medications that are going to treat constipation in our patients, especially with our elderly patients, because they don't pass as many bowel movements as younger people do, for many factors ranging from their age to the medications that they take, as well as the fact that their body just doesn't require as much food as younger patients, and their metabolism slows down as they get older. So you wouldn't want to introduce a drug that's going to slow that metabolism down even more. So with drugs like oxycodone, it's very common for elderly patients to go days or weeks without passing a bowel movement. And you don't want that, because that can cause a bowel obstruction or some kind of bleed throughout the stomachs or the intestinal systems. Signs of overdose of this drug in particular are going to include pinpoint pupils, extreme nausea and vomiting, extremely low blood pressure, weak pulse, difficulty breathing. The difficulty breathing and the respiratory arrest are definitely the extreme of the extremes. A lot of patients who pass away from opioid abuse, it usually comes as a result of respiratory depression. You're going to also see coma, increased sweating, extreme mood swings, confusion, delirium, and seizures. Seizures are something that you should monitor for if your patients have a history of epilepsy, or they have had other diseases or instances such as stroke or heart attack that may raise the risk for them having a seizure at some point in their life. These signs are going to vary from patient to patient, and it's going to vary depending on the dosage. If alcohol or other drugs were present, alcohol is definitely something you want to monitor for, because with a lot of people who pass away from opioid abuse, alcohol is also present within the system. Whether the drug was extended release or immediate release, oxycodone does come in extended release formulations where it spreads out how much of the drug that the body gets over time versus its immediate release. formulation where it gives all the drug at one time, so it's metabolized a lot faster. So this does raise the risk of having drug interactions or side effects. And another factor could be if the drug was used in an illicit manner and broken down to the point where it could be injected directly into the vein. So it would completely avoid the first pass metabolism and it would instantly go to the brain. So your patient is going through a couple days or instance where the body isn't able to get the drug that is normally getting and is accustomed to getting. So what are those withdrawal symptoms going to look like? Extremities of oxycodone withdrawal are going to include agitation, anxiety, muscle aches, increased tear production, insomnia, runny nose, and increased sweating. And as mentioned, like the point above, severity of these symptoms are going to range from patient to patient. It's typically on how accustomed the body is to having the drug, how accustomed or how prone it is to being able to, in a sense, weather the storm between not having enough drug that it's used to having. And it's imperative that we as pharmacists monitor the progression of these patients, because with the withdrawal symptom, if there's abuse potential, if someone is experiencing withdrawal, they're more likely going to go back or revert back to using the drug just to alleviate the feelings of withdrawal symptoms. And just as a quick note, the withdrawal symptoms are going to be the complete opposite of what the long-term effects are. And like with the long-term effect, when you have the withdrawal symptoms, it's going to be the extreme of all of them. So it's not just going to be your normal test anxiety. It's going to be anxiety to the point where our patient is having panic attacks, feeling like they're going to die, or anything to that extreme, which is why it is very important that we stay on top of our patient's treatment regimen to prevent them from, one, not having overdoses, but at the same time preventing them from going into withdrawal. So the patient, the prescriber, and the pharmacist have all come to a conclusion that maybe we need to look at some treatment options for our patients to prevent the current abuse or the risk of abuse from taking place. So what are the pharmacologic options? You're going to have methadone, which is going to aid in the withdrawal symptoms, and it's also going to be used as long-term maintenance for opioid dependence. Methadone itself is an opioid, but it acts long-term, so it's not going to be distributed throughout the body as quickly as oxycodone or other opioids are. Methadone is very common just because it kind of alleviates the risk of withdrawal symptoms, and it can be used as an aid, but at the same time, you still have to monitor it because, like I mentioned before, methadone is still an opioid medication, and it has a high risk of abuse potential. Cold turkey is never a good option for opioids because of the extreme withdrawal symptoms mentioned before. Buprenorphine or Suboxone is going to be used as a detox treatment for long-term maintenance, and this is a very commonly prescribed medication for people who are recovering from opioid abuse. Clonidine is an antihypertensive medication, but it is used in this case for treating anxiety, muscle aches, sweating, and other symptoms associated with withdrawal. You want to monitor clonidine just because you wouldn't want your patient's blood pressure to drop extremely low. As mentioned before, low blood pressure was a sign of overdose. So that's definitely something that you want to monitor. To go along with the pharmacologic treatment, you want to input your patient into some kind of a support group or some kind of a group where they have a psychotherapy aspect as well as the pharmacological therapy aspect. Opioid dependence is one of those battles that you don't want to fight alone. As with any recovery treatment, talking and just sharing amongst a group of individuals that's going through the same battle or has been through the same battle can really excel a patient's treatment journey, because in simpler terms, it just reminds that patient that they aren't alone and that they can overcome this issue that they're facing. So the role of the physician, they're going to be prescribing one of the medications above, and they're also going to be responsible for writing prescriptions that taper down the oxycodone from what the dose was that was causing the abuse or the extreme long-term symptoms. Many times, right there. So as mentioned, they're going to monitor dosages remove or add different medications. So the role of the pharmacist is going to be seen a lot more than the physician will by our patients. And typically patients are going to be more open to their pharmacist just because a lot of times there's more rapport between those two individuals. So our role is going to be increasingly monitoring the patient's treatment progress, forming an interpersonal relationship where the patient will be comfortable opening up to us and giving us a clear understanding of is this working? Do I feel like my battle is getting any easier? Do I feel like I want to continue, pushing the fight for sobriety? Like our patient will 9 times out of 10 be willing to share that with the pharmacist, and then we'll take those notes, those observations, and give them back to the physician, and then the physician will address treatment as needed. But like if you take a camel to a water, you can't force the camel to drink. The psychological willpower of our patient is the most important thing when it comes to this issue. The patient has to want to not be abusive to this medication. At the end of the day, they have to want to push for sobriety, for just an overall healthy state of mind. Both with their body and with the psychological aspects that comes with the abuse or the risk of abuse that they might be facing. So just as a quick summary of that, medication compliance is very important, as well as putting our patient in detox centers and group sessions if they're open to it. Hopefully they will be, because these group sessions and detox centers have been proven to be very effective in aiding in our treatment. So as a final reminder, opioid dependence should never be treated by stopping cold turkey. The risk of death from withdrawal is a high possibility. Patients should be tapered off of opioids by using a combination of the above treatment options to aid with the withdrawal symptoms as you're tapering down the dose of that opioid. The group sessions and medications are only meant as tools to aid in the patient's journey. The patient themselves really determine the success or the failure of the treatment above. And above is just a picture, my works cited, and my name. If this was folded up into a pamphlet, these are the first 3 slides that you would see first, and then this. But I do thank you for stopping by and learning just a little bit about oxycodone.